So how does this fit into the dermatology scenario? And I'm just going to move on just to show you what I think is really the most important thing here. In dermatology, we prescribed about 8.1 million prescriptions in 2011 in dermatology. And if you look in 2012, about the majority of that, 6 out of 8 was 6, if you put 6 over 8, was tetracyclines, commonly used for acne and rosacea. So what can dermatologists do? Well, first of all, don't prescribe antibiotics topically as a monotherapy. And we do have data with clindamycin now that you will select out more and more resistant strains and higher P. acnes resistance, at least, when you're utilizing it as a monotherapy. So at least be utilizing in combination with benzoyl peroxide as much as you can. And this data has been published. So the suggested approach would be, when you're prescribing an antibiotic and you feel you really need it for a patient with acne, you're going to utilize it in combination with a good topical regimen, but be thinking about your exit strategy of when you're going to want to withdraw that, and make sure the patients know that they play the #1 role. Because if they're not consistent with their topical, it's going to be hard to get them off the oral. So when they ask, well, the mother asks or the father asks, well, what about antibiotic resistance? We hear a lot about that. They play the biggest role by being compliant so they can eventually get off. And I think there is data. We have data with topical retinoids, and we also have probably our longest term studies now with benzoyl peroxide adapalene in actually being able to hold a lot of these patients in relative remission, not 100% when they're on antibiotics for 3 months with the topical, and then you transcend them to the topical. So I'm going to stop at this point, and hopefully that gives you an overall picture. It's difficult because we sometimes don't have other options, but we at least need to be accountable for what we're prescribing and what it might do.